Recording in progress.
And called on rich countries who had met their domestic needs to forfeit more volumes, and instead of administering third shots. I just wondered if you had any reaction to that, and how does it affect the vaccine buying plans of the AU's mechanism, AVAT, and also of individual African governments?
So the African Union member states have recognized that they have to count on their own capacity and capabilities, at least, to meet some of their vaccine demand. That is why we really need to celebrate the 400 million doses of vaccines that AVAT has secured. If you translate that to double doses, the equivalent of double doses, they represent 800 million doses. Remember, our denominator is 1.6 billion. That is what, when we stated as a target of immunizing up to 60% of our population, the required number of doses was 1.6 billion. We definitely need to adjust that number upward, given what we now know. So if you now put that, the AVAT doses in context, there is almost like securing up to 50% of those doses there. Now, the question he asks is pertinent, because even with the AVAT doses, it doesn't still allow us to get to a target of immunizing at least 60 to 70% of our population. That's why the partnership with COVAX and other bilateral donation is so important. Now, if countries begin to use or program the administering of the third doses there, it becomes problematic to achieve that other the other requirement of meeting our 60% immunization there. So I think that will continue to be a challenge. The problem we have with the third doses is that we have not seen enough science behind that. And what do I mean by this? First of all, we do not know is at what point is the immunity, that is the level of neutralizing antibodies, decrease to a certain level that they stop offering you protection against disease progression. Remember, none of these vaccines will protect you absolutely from acquiring transmission there. So they do one thing, they slow down disease progression and hospitalization. So we just don't know that, and we have not seen data or evidence that suggests what we have that. Second is that even if we saw a decrease in the number of neutralizing antibodies, we don't have any evidence and science that says that if you get to a certain threshold, you progress quickly towards disease, or you actually are infected and you get hospitalized. We have not seen that. Those are the parameters that will enable us to actually make appropriate judgment as to when you require a third booster. Lastly, and very importantly, is that all vaccines are not made the same. So science will need to tell us that for every vaccine that you receive, this is the appropriate timing at which level the booster. Whether you're receiving the AstraZeneca, Johnson & Johnson, Pfizer, or Moderna, or Sinopharm, or any other vaccine, we need to use science to inform us at what level you need that third dose or booster. Without that, we should be gambling. We would all be saying we need a third dose, but it's not informed with science. So, for example, vaccine today, and then after 6 months, I get another booster. When do you expect to get the fourth dose? And when do you expect to get the fifth doses? So it is really still confusing to me as to why we are moving towards a vast recommendation for a booster doses there. I fully understand that suppress diseases of neutralizing antibodies have decreased significantly because of this, their immunocompromised state. But for otherwise healthy individuals, that will require that we lead to a third dose or a booster dose. If we continue to do that, then we should actually increase the manufacturing capacity in developed world so that they should ramp up the production of vaccines to immunize their own population to get to that level. We have seen what is going on in Israel, seen what is going on in the United States, where even after immunizing to a certain level, you are still challenged by the introduction of a new variant. Today is the Delta variant, tomorrow we just know which variant will be out there.
Thank you very much.
much for that. To Coletta Wanjohi, and Coletta is with the Feature Story News, FSN. Good morning, Coletta. Please go ahead with your question.
Thank you, Madam Wine. Good morning. Good morning, Doctor. My question is just a kind follow-up to the issue of community surveillance as far as trying to meet the problem of testing is concerned. We'll begin to send out community surveillance tips and all. How will that work in a situation whereby a lot of people within the community do not feel the urge to volunteer to just go and test for the sake of it? Thanks.
I think, Coletta, that is a very, very important question. That is exactly why we need to launch a vast campaign to address, to shift our testing strategy from testing those who are traveling and or those who have symptoms and want to confirm that. If we keep doing that, that will not enable us to conduct appropriate surveillance in the community. Surveillance doesn't just target people traveling or individuals who feel like they are sick. Surveillance is a continuous activity that you use a systematic approach to collect data so that you can interpret it and act on the data there. So, for example, if we were to sample Addis Ababa, we will develop very standardized protocols that will enable us to look at different components of the community so that we know exactly what the positivity rate is, and we can compare that with after 1 month if we do the same sampling to see if there have been changes at the level of positivity rate there. I think we also have to build in a counseling component, which we say that, well, if someone is tested, you take upon your own self-responsibility to extract yourself from the community, stay home for a few days and do a repeat testing. So testing to know your status, testing to confirm symptoms will still go on, but at least we'll be taking action to that. But we'll also be looking at a community activities app. Say, for example, if we did community survey in one section of Addis, and we are doing that systematically. And the positivity rate is 9% this month, and we do a repeat survey and it's 12%. It means something is going on in that community. We can either do enhanced campaign there for people to ensure that there's public health measures being implemented to slow it down. What we really don't want to be is where suddenly you reduce the peak of the pandemic to a certain level, maintain it for 2 months, and then you see these spikes that come in like almost like a lightning. They come up very steeply and they overwhelm our health system there. So it will be challenging, but again, we are in a very tough situation. We have to use everything. And the centrality of good public health is surveillance. So we really need to bring surveillance back to bear as an important tool to fight this pandemic.
Thank you very much. We go now over to South Africa to say good morning to Sophie Mokoena. And Sophie is the SABC foreign editor. Good morning, Sophie, and go ahead with your question, please.
Dr. Nkenkasong, yesterday, both the UN Secretary General, when he was speaking to the SABC in New York, and also the World Health Organization's director, Dr. Tedros, they were very, very frustrated and visibly angry in terms of access to vaccines. You have the two big gatherings coming, the G20 and the United Nations General Assembly, where you'll have world leaders. What is your message to the world leaders on issue of access to vaccines? Because it looks like the Sub-Sahara is lagging behind and there's no political commitment from world leaders to assist the developing South.
So, Sophie, I think that is, of course, a very pertinent question. I believe, and you all on this platform are witness to this statement, that we have been as vocal as we can as the African Union, as Africa CDC, with respect to the immoral, the morality of lack of access to vaccines on the continent. From days one, we have been very, very vocal about this. And we were the first to state, I remember on the 31st of January last year, that I was very clear that we are moving towards a moral catastrophe. I was very, very clear. And at that point, people said I was hard, but it's not. Today, we are where we are. Africa's total number of people that have been fully vaccinated is 3%. So my message to the two important gatherings that you just mentioned is that we cannot continue to politicize this situation by making statements that we don't follow through with firm commitments. And we just pledges that do not translate into reality. I think that is one. Second is that we are not, as a continent, very keen in any definition of vaccine diplomacy that would mean that people make statements in the media that are not really backed with reality. Pledges do not put vaccines into people's arms. I think we want re-vaccines, not just pledge vaccines. When the G7 or G7 meeting, I believe, in London just a few weeks ago, you heard all the pledges that were made. I mean, up to about 1 billion doses of vaccines were committed. We have not seen 1 billion doses of vaccines. I just gave you our denominator. Our denominator is that we need to strive to get to 1.6 billion doses of vaccines. We are far from that. I insist on that denominator because when a country says we are giving Africa 10 million doses of vaccines or 15 million, we should always square that with a denominator. How do we get to 1.6 billion doses of vaccines? I think that my call to action will be that we are not going to win this war against the pandemic. I mean, we collectively, including the developed world, if we do not vaccinate everybody at speed. Otherwise, we should be embracing ourselves to living with this virus as an endemic disease going forward. That is, all I can say. I think we are not yet there. We still have a window of opportunity if we cooperate, if we really truly express global cooperation and solidarity and try to expand vaccination quickly. The quickest way to end this pandemic, Sophie, is to quickly vaccinate.
Thank you very much. We go now to Sydney Kawadza, who is the editor of a magazine called The Anchor. And his question is to do with media and how they can cover the COVID-19 pandemic. So he says, going forward, what means do you think that the media should adopt to ensure that people get the proper information as it relates to the fight against the COVID-19 pandemic?
So I believe the mainstream media has done exceptionally well in covering the vaccine situation, in my view. I mean, they have been extremely clear. I mean, most media organizations do have their own tracking systems. They share the right information. Where the greatest challenge has been with the social media. I mean, that is, and we have always said that, I mean, we can, don't underestimate the power of one, which means if you receive false information, don't share it, okay? Because those who design those false information and miscommunication, they work on us mindset and psychology. They know that if they send even the most unbelievable information, it will be ridiculous to you. You laugh at that, but then you share with the second person. They also look at it and they laugh, they share with somebody. And we should not do that. When we get that kind of a misinformation, we should stop it. Okay, just delete it from where, and don't underestimate the action that you take at the individual level, how collectively it can become very powerful. The media, the mainstream media can continue to and should continue to help us encourage the population to go out and get their vaccines. I see that the situation has changed a lot on the continent. There's really a vast movement towards acquiring